Welcome to The Explainer. Today, we're cutting through the noise and bringing some much-needed, evidence-based clarity to a deeply emotional and honestly highly complex topic in women's health. We're going to look at the realities, the science, and some surprisingly empowering medical options for patients navigating life right after risk-reducing surgery.
Think about this. What if the surgery that literally saves your life plunges you into an entirely new medical nightmare? It's a devastating reality. Patients who find out they carry genetic mutations like the BRCA mutations face an incredibly brave but agonizing decision, right? Undergoing life-saving surgery to remove their ovaries and fallopian tubes. But what happens the day after that surgery? For a lot of people, the very procedure that shields them from cancer abruptly throws them into a severe, often totally unmanaged medical crisis.
Let's look at the numbers to really grasp why this decision is made in the first place. For individuals with pathogenic BRCA1 mutations, the lifetime risk of developing breast cancer is just staggering. We're talking 57 to 72%. Because of these massive risks, clinical guidelines strongly advise patients to undergo risk-reducing surgery somewhere between the ages of 35 and 45. So yes, it is an absolutely necessary proactive step to save a life, but the systemic shock it delivers to the body, it's profound.
Now, everything in our explainer today is grounded directly in a recent, comprehensive narrative review published by the American College of Obstetricians and Gynecologists, or ACOG. This is absolutely crucial because it ensures the insights we're unpacking are rooted in the highest standard of current clinical evidence. We're bypassing all the misinformation that usually clouds this specific area of women's health.
Section 1. The BRCA Menopause Dilemma. So we really need to highlight the stark contrast between two wildly different physical experiences. Natural menopause usually happens around age 52, right? And it features a gradual, rolling decline in hormones. Surgical menopause, on the other hand, is literally like falling off a cliff. The body goes through this rapid, abrupt drop in serum estrogen and testosterone. And this triggers sudden and severe vasomotor symptoms, what we commonly call hot flashes and night sweats, along with severe mood disorders and sleep disturbances. Plus, observational studies show this sudden estrogen deprivation accelerates long-term risks. We're talking coronary artery disease, cognitive decline, and osteoporosis.
Section 2. Rethinking Hormone Therapy Risks.
Okay, let's address the elephant in the room. Does taking hormones to relieve these agonizing symptoms actually increase the risk of the very breast cancer these patients just had surgery to avoid? Ever since the 2002 Women's Health Initiative study, there has been this dramatic, deeply persistent fear of menopausal hormone therapy among both patients and doctors. But, as we're about to see, while applying that 2002 data to young, surgically menopausal BRCA carriers is fundamentally flawed.
Actually, the modern medical consensus is a huge plot twist for a lot of patients. The current evidence clearly shows that for individuals with BRCA mutations and intact breasts who undergo this risk-reducing surgery before age 45, initiating systemic menopausal hormone therapy is not associated with an elevated risk of being diagnosed with breast cancer. In fact, withholding it, that might actually be doing way more harm than good when you factor in long-term cardiovascular and bone health.
If you look closely at the data from the ACOG review, specifically, there's this 2018 prospective cohort study by Kotsopopoulos and colleagues that looked at nearly 900 BRCA1 carriers. We see something incredible. For patients undergoing surgery before age 45, the use of estrogen-only therapy was actually associated with a greater than 50% reduction in breast cancer. Just let that sink in for a second. Greater than 50%. Instead of causing cancer, the right type of hormone therapy in this specific age group dramatically reduced the risk.
And this data builds into a highly actionable clinical strategy, because estrogen-only therapy is shown to be safer and, like we just saw, potentially protective compared to estrogen combined with progesterone. The clinical takeaway here is huge. Clinicians caring for women with BRCA mutations should actively consider offering a hysterectomy alongside the removal of the ovaries and tubes. By removing the uterus, the patient completely avoids the need for progesterone-containing therapy, meaning they can safely use that estrogen-only treatment.
Section 3. Non-hormonal hot flash relief.
Now, of course, not every patient is a candidate for hormone therapy, and some, they just might choose not to use it. Totally fair. Fortunately, the menu of FDA-approved non-hormonal options is expanding super rapidly. Right now, there are two primary FDA-approved non-hormonal therapies for vasomotor symptom relief. There's a low-dose antidepressant called paraxanthine salt and a newer medication called fezolinetant. There's also a really promising drug called elinzanetant that's currently under FDA review. Fezolinetant and elinzanetant are part of this brand new class of drugs called neurokinin receptor antagonists. Basically, they work by modulating receptors directly in the brain to stop hot flashes right at the source.
So how well do these new non-hormonal drugs actually work? Well, fezolinetant reduces the frequency of those debilitating vasomotor symptoms by about 65%. That is remarkably close to the 75% reduction we typically see with traditional hormone therapy. And the best part? It works fast. We're talking rapid relief, often starting within just one single week of use and entirely without any loss of bone density over time.
Section 4. Addressing sexual dysfunction.
Now, we really need to transition to a profound but frequently unspoken challenge that follows surgical menopause. And it's so vital that we validate the patient's lived experience here. After risk-reducing surgery, a staggering 74% of women experience sexual dysfunction. Compare that to about 40% in natural menopause. The leading culprit? It's genitourinary syndrome of menopause, or GSM. This is a progressive condition caused by that massive estrogen loss, leading to severe vaginal dryness, irritation, and painfully uncomfortable intercourse. Between 47 and 73% of surgically menopausal patients suffer from this. And listen, it requires highly targeted treatment because it absolutely will not improve on its own.
So how do we treat it?
Well, moving beyond basic over-the-counter moisturizers and lubricants, vaginal estrogen therapy is FDA approved and highly effective. But here is the critical, absolute must-know fact you need to take away. Despite the terrifying warnings you might see printed in bold on the package labeling, modern observational data confirms that localized vaginal estrogen does not elevate the risk of breast cancer recurrence. Period. It's safe, it relieves symptoms effectively, and its use is actually even associated with reduced overall mortality.
And there's another layer to this dysfunction that carries a really heavy stigma: hypoactive sexual desire disorder, or HSDD. This is medically defined as a persistent absence of sexual desire that causes marked personal distress. Surgically induced menopause creates a significantly higher prevalence of HSDD, and the science points to a very clear reason why. It's that sudden, abrupt decrease in serum testosterone levels that literally happens the very moment the ovaries are surgically removed.
Now, while there are currently no FDA-approved testosterone formulations made specifically for women in the United States, clinical data is showing some real promise for off-label use. Clinicians can prescribe a low-dose transdermal testosterone. Specifically, we're talking about 1/10 of a 1% formulation that's normally designed for men. The goal here isn't to flood the body with hormones. Not at all. It's simply to return free testosterone levels to normal, pre-menopausal ranges. And the studies showed this approach actively improves sexual desire for surgically menopausal patients suffering from HSD.
Section 5. Empowering patient choices.
All right, so we've covered the risks, the completely understandable fears, and the breakthrough treatments. The overarching theme from this ACOG review is empowerment through shared decision-making. No patient should be left to suffer through the severe consequences of surgical menopause simply out of outdated fears. Whether you and your doctor decide on systemic estrogen-only therapy to protect your heart and your bones, or maybe highly effective non-hormonal pills for those hot flashes, or targeted localized treatments to restore your sexual health, managing these symptoms isn't a luxury. It is an absolute, essential component of protecting your long-term health and your quality of life.
We're going to end our explainer today with a bit of a challenge. You took the brave step to reduce your cancer risk, but you do not have to sacrifice your well-being in the process. So, what does this all mean for you? Are you ready to rewrite the rules of your menopause journey? Take these evidence-based facts directly into your next doctor's appointment. Ask the hard questions, demand a tailored approach, and fiercely advocate for the quality of life you absolutely deserve. Thanks so much for joining us on The Explainer today.